My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN project. And thank you all for joining us today. And our friends at Cherokee Health Systems in Tennessee for selecting and hosting today's session, which is called Anxiety in Adolescents, a Primary Care Approach with Dr. Najah Musacchio. Dr. Musacchio is a board-certified pediatrician with expertise in adolescent and young adult health, patients aged 10 to 25. She has extensive experience in academic and community-based settings providing mental health care. She was an attending physician in the Podosnak Family Division of Adolescent and Young Adult Medicine at Lurie Children's Hospital of Chicago, and assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. There, she started and directed the Mental Health and Primary Care program, providing consultative care for mild to moderate anxiety, depression, and ADHD, and educating residents on how to incorporate mental health care into their future practices. As a staff physician at Girls to Women Health and Wellness, Dr. Musacchio provided primary care and collaborative mental health care, including eating disorder treatment for girls and young women. She was also formerly the lead clinician at Uptown Teen Clinic in Chicago. She has spoken on many adolescent health topics as well as mental health care to community groups, trainees, and clinicians. It's a pleasure to have you here today, and I'll turn it over to you.
Thank you, Jill, and thanks everybody for having me. I'm going to share my screen. All right. Can you all see that?
Yes.
Okay. All right. So I'm going to be speaking about anxiety in adolescents today. If any questions or comments come up along the way, please put them in the chat and I'll try to address them as I go. So here are a few housekeeping slides. Learning objectives for today are to describe the diagnosis and management of common anxiety disorders in adolescents in a primary care setting, and to describe strategies for anxiety psychoeducation for families. What is anxiety? Does anybody know? Has anybody ever had anxiety before? Anxiety is the most common mental health condition. There was a national study that showed that probably around 8% of kids aged 3 to 17 have a current anxiety disorder. And those numbers are sky high. We all know that's increased since COVID, but it had even been trending upwards in the years and decades prior to COVID. Most cases of anxiety are untreated, unfortunately. Fear and worries are a normal and necessary part of human development. If I wasn't scared that I was going to get hit by a car when I was walking across the street, I might just walk without even looking. So it is necessary for our safety that we have certain fears. But anxiety disorders occur when those fears or worries are excessive. So they're like beyond what would be reasonable in terms of risk. They're developmentally inappropriate. So maybe it would have been typical or acceptable for someone to have that certain fear when they were younger, but now they're kind of like too old for this. When the fear or worry persists after the risk or the danger is already passed, and when those fear and worries interfere with a person's function. This is the avoidance anxiety cycle. And so this is really important to kind of like how anxiety disorders come about in the first place and how they perpetuate themselves, how they get worse, and also offer us an opportunity to intervene and actually treat an anxiety disorder. So let's say if I have social anxiety and I'm really worried about going to a party on Saturday night, in the days, hours leading up to the party, I'm getting more and more stressed out, more and more nervous. My hands are sweaty every time I think about it. My stomach's been hurting. I can't even eat anything. And then like an hour before the party, my anxiety is like hitting a peak. I'm so scared. And I'm like, you know what? I'm just not going. So I text my friend, I'm not going to be coming. And then immediately I feel a huge sense of relief. I'm like sitting on the couch, relaxed. Okay, it really feels like I did the right thing here. I feel so much better. However, what I've done is that I missed out on an opportunity to learn coping skills. If I had gone to the party and walked in the door, my anxiety would have been an all-time peak. And maybe I would have even felt very panicky, but I may have seen somebody across the room from my geometry class, and then I ended up talking to that girl. It was really awkward, but okay, I like survived it, and I ended up coming home and it was okay. But in that process, I would have learned how to deal with a situation like that. Also, I've now reinforced the idea that since I didn't go, I avoided a catastrophe. If I had gone to that party, it would have been a disaster. So thank God that I didn't go. And in the long run, I end up having more worries than I did in the beginning. So maybe now if someone invites me to Starbucks and I don't know one girl, but I know three, I'm just not going to go. And so this is how people with anxiety end up kind of boxing themselves into a corner and is the main source for the functional limitations that they end up having. Risk factors for anxiety, number one is anxious parents. So parents, we are to blame for everything. So I'm just kidding. So parents, if you see a family history of anxiety in a patient's chart, you definitely want to be on the lookout for the child to develop an anxiety disorder. And there's a lot of different reasons for that. This could be genetic. Also, an anxious parent might be modeling anxiety or modeling unhealthy coping skills. Anxious parents tend to be more over controlling, so they might want to try to micromanage everything that a kid is doing and kind of sending them a message that they are unable to do something or else something really bad is going to happen to them. And also anxious parents, out of love for their kids, end up accommodating their kids' anxiety. So it's very hard to see your kid in pain. And if a kid, let's say, is calling you from school to come pick you up because they're having a stomach ache or they're getting really nervous and stressed out, I'm just going to go get them. Like they can't be in school like this. And so I'm trying to do something to protect them, but actually in the end, what it ends up doing is it just perpetuates their anxiety. Temperament might play an issue. Some kids are nervous, even like in preschool. They might have a personality that trends towards this. A history of trauma, other mental health conditions, and then other anxiety disorders too. So anxiety disorders don't tend to just be like one on their own. It's like if you have one, then you're more likely to have another, like at the same time, or maybe later in life. I'm just gonna look at this chat here to make sure. Okay, it's not questions. Other risk factors, this is something that I feel very passionately about. And if you like, I can talk about it for the next 2 hours, but I won't. But I think that there are certain cultural factors that play in this loss of independence amongst kids and risky play that is involved in that as well. And this is an article, this picture is from an article from England where it kind of tracks four people, different generations in one family, how far an 8-year-old was able to go on their own. So in 1919, the great grandpa walked 6 miles to go fishing. And then this world shrinks down over time to the mom in the 70s, where she was 8, she was able to walk half a mile. And then current day, he can only walk 300 yards to the end of his street or the end of his driveway. So this effort to kind of keep kids safe hasn't really actually made them safer in most cases. And is actually, I think we've sent a message to kids that the world is a very unsafe place and that they don't really have the skills to manage it. And so we're going to kind of keep them really close. Obviously, there are trends in certain communities where this might not apply. Hazards of anxiety. So why do we care if somebody has anxiety besides the fact that it's completely miserable? It can also in the long run cause you to have a depressed mood. Like it really stinks to just constantly be worrying and stressing about stuff. And you end up feeling very demoralized and just kind of hopeless about the future. There's also a significant somatic burden with anxiety. A lot of people end up having physical symptoms that they end up coming in for medical care, going into the emergency room, getting tests. and also adding to medical costs. It can also affect our psychosocial function, where you might not participate in activities that you would have normally or would have liked to, or it can affect your relationships with other people. And then some people end up coping with their anxiety by trying substances. Specifically, young women in college, if they have social anxiety, they might be more likely to try to like drink alcohol to try to make themselves feel relaxed at a party. There are common presenting factors with anxiety in kids. Midline physical symptoms are very common. And they're these just kind of like vague complaints that you might see in primary care just on their own, not even talking about anxiety, but it should definitely make you think it or wonder if there might be an anxiety issue going on. Having a headache, feeling dizzy, mouth tingling, lump in the throat. That's a common one where you feel like it's either there all the time or you're unable to swallow pills because of it. Or kids might talk about like having a worry about gagging, choking, throwing up in front of their friends. Some kids might not even like eat lunch in the cafeteria because they're so worried about that. Feeling short of breath, feeling like you're hyper aware of your breathing patterns, chest pain, stomach aches, feeling like you have to go to the bathroom really bad immediately, tingling in fingers. I don't really see that often. And then also parents might describe them as being really irritable and crabby. Younger kids, they might have like crying or screaming, get really angry when they're faced with something that's causing them a lot of fear or worry. Difficulty concentrating. Sometimes this is mistaken even for ADHD. If you're constantly perseverating and worrying about something, it's very hard to turn your mind to working on your calculus homework. Sleep disruption, obviously, sometimes you just can't turn your mind off at night. And in fact, that's when a lot of anxious thoughts come, when you're lying in bed and there's not really another distraction going on, your mind might start turning and not stopping. And then of course, if someone is not getting enough sleep, then that even just worsens your anxiety. Social withdrawal, so not attending things that you used to attend. And then missed school. So yeah, if someone has a cold or an illness, they're going to end up missing, let's say, a day of school. But if there's a pattern that you notice in your patients where they're getting sick and then they're missing like 3 days in a row of school, 5 days in a row of school, like that's just not typical. And that should signal that there is some kind of anxiety going on related to school or maybe related to something social or separation from the parents, but something is going on there. Another red flag is kids who are consistently late to school because maybe they have a headache or their stomach is hurting in the morning, or kids calling home asking to get picked up in the middle of the day because they're feeling sick with those midline physical symptoms. And for kids who have anxiety related to school resulting in this kind of school avoidance pattern, the biggest priority is getting them back to school, is putting them in school despite feeling a little bit sick or nervous. You need to have a concrete plan with the family about like this is a reason to stay out of school. Otherwise, you need to be in school. So I'm going to run through some specific types of anxiety disorder that are pretty common in primary care. Social anxiety occurs when someone has an intense fear of interpersonal scrutiny. So yes, we all care about what other people think about us, but for someone with social anxiety, it goes way beyond that, where the fear is very intense, where you're so scared that you're going to be humiliated, to the point where you avoid situations where it might occur, or else if you stay in the situation, you have intense anxiety. In clinic, you might notice that the person is speaking quietly, maybe they blush easily, they might even be shaking talking to you. And it has to happen not only with adults, it also has to be with people of their own age. And symptoms need to go on for at least 6 months. Generalized anxiety disorder is when you worry about basically everything and anything at all times. Like what's the that movie? Everything all at you know what I'm talking about. But everything that's out there, like you will worry about it to the nth degree. And kids with generalized anxiety, they might seem to be high-strung, perfectionists, and they also might have trouble in like performance situations where the pressure is really on, like a big test or a big final or big game, something like that. And kids with generalized anxiety also need to have at least one physical symptom on most days. Restlessness, fatigue, difficulty concentrating, or your mind goes blank. So that can come up in one of those like test situations where a kid might say like, I had the test and like, I just sat there, I completely blanked. I turned in a blank test. Other common anxiety disorders are specific phobia. That tends to be more in like the younger kids. When you have fear of a specific object or situation that's out of proportion to the actual danger of the item. Separation anxiety is when you fear separation from an attachment figure, like a parent. You really worry about harm coming to that person. And so you might hear a parent talk about how they can't ever leave the kid at home because they get so worried and nervous being there by themselves. Panic disorder. So panic disorder involves recurrent panic attacks. I'm sure you're all aware of what a panic attack looks like. It is like a very fast, huge jump in anxiety where you have a fast heart rate, maybe trouble breathing, you feel overwhelmed, you feel like you're going crazy, you can't think straight, and it's just very horrible. But the worst thing is that not only do you have the panic attacks, but also then you have at least a month of intense worry about having more panic attacks in the future. Alternatively, you might just make some changes like, let's say I get panic attacks in whenever I go in an elevator. So I'm like, I'm never going in an elevator again. Easy, done. So now I don't have panic attacks anymore, but you still have panic disorder. When someone comes in the office for anxiety, I think it's very helpful to use an assessment tool to get an idea of where their symptoms are. And I know a lot of people like to use the GAD-7. That is designed to evaluate generalized anxiety, and it's just 7 questions. I really like to use the SCARED. The SCARED is a 2-page evaluation, and it's free. It's on the World Wide Web, and it's in a number of languages too. And there's a form for the child, and there's a form for the parent. So if I was seeing somebody for the first time, I'd want to give them each a copy. And it's validated ages 8 to 18. And the reason I like it is because it evaluates a lot of different types of anxiety. So it goes far beyond just generalized anxiety. It asks questions about panic, separation, and a bunch of others. So you can tally up their scores and then you get a total score. A total score of 25 or higher is suggestive of an anxiety disorder. And if a total score is 30 or higher, that's even more specific. So you can track these scores over time. And maybe if you're seeing somebody for anxiety the first time, their score is 35. Next time it's lower, great. And then you can share that with the family. So I find that very useful. It does take a few minutes though to run through it. So maybe they can do it in the waiting room if possible. And for the history, we want to ask how the patient is coping with their anxiety. Like, what have you tried to help yourself feel better? What has worked? What hasn't worked? Assess their function. So how does this worry that you've been having affect your life? Are they going to school? Triggers. Did anything happen before this anxiety came about? And then you want to make sure that they don't have another condition that can either mimic anxiety or that can co-occur with anxiety, like depression and suicidality. So when I would see people for a mental health evaluation, I would give them a depression eval, I would give them the PHQ-9 and a SCARED. And then ideally, I would also give them a Vanderbilt for ADHD because I'd really want to make sure that I'm not missing something that first pass. Substance use, and then sleep. Make sure they don't have a medical etiology. I mean, that is so rare in a kid, but potentials could be like maybe they're anemic and that's causing their heart rate to go up, or they have a thyroid condition. Therapist input is so important. If somebody's already been seeing a therapist, like I would always reach out to them, especially if I was starting medication, just to make sure that we're all on the same page in terms of diagnosis and severity of their symptoms. What can we do as PCPs in our office when we think someone has an anxiety disorder? There's a lot we can do. We're not counselors, we're not psychiatrists, but first of all, we can offer just kind of generic support to our patients. So what I would say is, it sounds like you've been going through a really hard time recently, and I'm so proud of you for coming in today and talking to me about this. I know this has been really hard to talk about, but I have seen so many kids experience something like this and they end up feeling so much better. And you absolutely can feel better. The good thing about anxiety is that it's totally curable. So I have a lot of hope for you, and I'm here for you to support you in this. And if you have any questions that come up before I see you again, please let me know. The next thing we can do is talk through kind of like some more anxiety directed recommendations. We can talk to them about the physical manifestations of stress if they're having physical symptoms. And I'll talk more about that in a few minutes. Relaxation techniques like deep breathing and meditation, mindfulness, a lot of this stuff is already, I think, kind of saturated in our society. They're teaching it even in some schools, but I do have some resources at the end of my talk. And I can also email you even more if you're interested in additional resources. Independence therapy is interesting to me. I mean, this is very recently has come up, and I also have a link at the end of the talk about it. But it's kind of coming from this concept that kids today have a lot less independence and risk taking. So trying to recommend to families that the patient try to do something on their own that they've never done before. So and it doesn't have to be related to their anxiety. It could be like cooking a meal at home or cooking dinner for everybody or walking to the store to get milk or biking to school by themselves, something like that. And how this pilot study showed that doing that, kind of like the feelings of confidence and competence that come with that, end up permeating into a person's anxiety and helping with that. So I feel like that's worth a shot, and it's free, and it could actually be really fun too for the patient. More recommendations we can make. So our thoughts are, where do I start with this? Thoughts are really an illusion. So a thought is not harmful in itself, right? Like if we don't act on a thought, it really means nothing. It's like a puff of smoke. Thoughts can be inaccurate. You can just look at my March Madness bracket and see how inaccurate thoughts can be. So it's not like we should like trust every thought or feeling we have. Thoughts can be unhelpful. And a thought of like, I wonder if something happened to my mom on her way to work. I wonder if there's something going on with her. Maybe I should check and call. No, I shouldn't do that. No, actually, it's so unlikely that she's hurt, but maybe she is hurt. And maybe she didn't text me and that's why she didn't text me back. Okay, having that kind of a thought in your mind is not helpful at all. Does it help prevent your mom from being hurt? No, of course not. It doesn't change anything. It's not helpful. So if I start to have a thought like that, I'm going to just notice it and say, okay, yeah, is my mom potentially hurt on the way to work? That's an unhelpful thought. Instead of battling it, instead of trying to convince myself that no, the chance of that is low, or, all this stuff going back and forth, that strife causes even more stress, and you're engaging with the thoughts and giving them even more power. So if I have a thought like that, I'm going to notice it and I'm going to accept it. And I'm not going to do any behaviors that would kind of give more power to my thoughts. So I am not going to seek reassurance. I'm not going to text my mom to make sure she's okay and she didn't die in a car accident on the way to work, because I'm stopping those behaviors. And if I would ask my mom, she should not be reassuring to me. She should not be explaining to me how she's okay and everything's okay and the chances. No, she should just kind of not engage by saying, you know how to deal with that. And then finally, avoid avoidance. So figure out with the families, identify where are they using avoidant coping skills. Is mom picking up daughter early from a get together with her friends because she's feeling uncomfortable? And then we're going to stop doing that. And a good gauge to see if we're pushing hard enough is that the kid does feel uncomfortable. Being uncomfortable is not dangerous. A thought is not dangerous. So we want people to kind of sit with their discomfort. So this slide is about the physical effects of stress on the body, and it's adapted from my old mentor, previous mentor, I should say, Dr. Sugarman, this also builds off some of Ken Ginsberg's work, and that's where the diagram is from. But if you have a patient who's been having a lot of physical symptoms, I think this is really important to talk through. And commonly, as a PCP, we're having patients coming in and saying like, I went to the ER or I saw a GI, and like nobody knows what's going on. And it's really up to us. Like the buck stops here. We have to be the ones to say, I think this is from your stress. And I think if we can manage your stress better, I think you're going to feel a lot better. So the way that I would describe it to patients is I would say, everybody has stress in your life, and you're going to continue to have stressful events in your life. So back in the caveman days, their stress was a tiger running at them. And our bodies don't tell the difference between a tiger running at you or the SAT that you have in 2 days, or how you keep fighting with your mom. So our bodies release adrenaline in order to fight that tiger or flight, or in order to run away. And that adrenaline has real physical effects on our body. So in order to push this adrenaline through our bodies, our heart rate has to go up to pump the blood. So the heart rate goes up, our blood pressure rises, and we start breathing more quickly. And then I would ask patients like, how does that make you feel? More nervous, right? Okay, so your body's like, oh, cool, more stress. Okay, here's some more adrenaline. And so that's what happens in a panic attack, is that your body thinks you're in danger when you're not in danger. And you have this flood of adrenaline. So out of heart rate, blood pressure, and breathing, I'd ask a patient, what can you control directly? Breathing. So the first thing that you want to do if you're feeling panicky and overwhelmed is deep breathing. Force yourself to deep breathe, because you're going to send a message to your brain, slow down the adrenaline, I'm safe. Your brain is sending you, or you're sending yourself, inaccurate messages about how unsafe you are. So this adrenaline pumping causes real physical symptoms for people. It causes the blood to rush away from your head and go into your legs and your butt so that you can run. So that's why you felt you can't concentrate, you have headaches, and you have muscle tension from all this blood rushing to your extremities. Your stomach hurts, you feel nauseous, you can't eat. All of this, these are real physical symptoms that you've been having. This is not in your head. This is not you're going crazy. This is real physical symptoms. So that feels really bad. And we want to people want to get rid of those feelings, and they can do it through unhealthy coping skills or healthy coping skills. The unhealthy coping skills, this is stuff, it's going to make you feel better so fast. But what ends up happening is you've created other problems for yourself, and your stress will come back. You've not solved that underlying problem. So I might ask the patient to give some examples of that, and I have them here on the side. On the other hand, healthy coping skills, they might not all work, but they're not going to hurt you. And if they do work 10%, 20%, they'll actually get at the heart of the problem. And so I would say I divide this up into healthy body and healthy mind. I'd ask the patient, what are 3 things you need for a healthy body? Nutrition. So I want to make sure you're eating 3 meals a day. We can't be skipping meals when you're stressed out. It's not going to give your body the nutrients it needs to try to fight this. Exercise is very important. Cardio is good because it raises your heart rate and teaches you that a raised heart rate doesn't necessarily mean you're anxious. Like it kind of gives you, You feel you're not immediately like pushed to like an anxiety mind state by a high heart rate. But a lot of different people like different things. It doesn't need to be on a treadmill running. You could be like lifting weights in your room, looking at yourself in the mirror. Could be walking your dog, doing something enjoyable, getting endorphins running. And then sleep. Teenagers today are not sleeping enough, and we need to talk to them about that and getting an earlier bedtime. And then I'd ask the patients, like, what are some things you do for a healthy mind? And run through those. And then I would really recommend by next time, try some of this stuff out. And then next visit, I want to hear what you tried. And did it work and did it not work? Moving on to treatment, medical treatment. Uh, so there was this CAM study 15 years ago that showed that the highest efficacy when we're treating kids with anxiety disorders is a combination of CBT, cognitive behavioral therapy, and I'll talk about that a little bit more in a bit, and sertraline or Zoloft. There was 80% efficacy a few months out. And that was slightly higher than the group that was treated with CBT alone or sertraline alone. And those were higher than placebo. They did this follow-up study years after that and found that about half of the kids had relapsed into anxiety again. A third were chronically ill, and then maybe like a fourth were in stable remission. So it's very common that the anxiety disorder might go into remission, but then it comes back again later in life when another stressful event happens, or maybe you start kind of coping with some of these avoidant coping behaviors. It can kind of creep up on you. In primary care, if we have a patient with mild or maybe moderate symptoms, we definitely want to try therapy first. So cognitive behavioral therapy. And we might want to start instead with an SSRI if they have, if they can't access CBT, and that might mean like in your community it's difficult to get into, or language barrier, insurance barrier, or if their anxiety is so high that they're not even willing to go into a therapist's office or put into effect like the homework that the therapist is giving them. Another common reason would be like if the person has tried CBT, maybe they've been in it for like a month, 2 months, and they're not getting better or they're getting worse. Then you'd want to try an SSRI. So if you have a patient with some of these more mild symptoms, I think you need to speak about this like explicitly with the family. Like if we do therapy first, I still want you to come back to see me again in month, 2 months, or whatever it is, to check in on how you're doing. Because at that point, like if you're not doing any better, then I think we want to try an SSRI instead. What we don't want to have happen is that somebody goes to therapy and then for 3 months stops because it wasn't helping, and then they come back to see you in a year and like stuff is so much worse at that point. If a patient is more in the moderate to severe range, then you'd want to definitely start with both. Consider referring to psychiatry if you're not sure about the diagnosis, if they had a really bad reaction to an SSRI, and if they failed 2 SSRIs, or maybe you tried an SNRI also and it didn't work, you might want to consider referral. There are a lot of different levels for a higher level of care besides inpatient, obviously. A step down from that could be partial hospitalization, which is when someone goes to a program all day long, but then comes home at night to sleep in their own bed. And then lower than that is like an IOP, intensive outpatient program. That's when you go for like a few hours after school, maybe like 3 days a week or something like that. So we have a lot of options for treatment if someone isn't at like the inpatient level. Of course, this is all limited by insurance, right? And then if someone has severe symptoms, severe impairment, like they're not going to school, refusing to go back, if they're failing outpatient, so maybe you've like stepped up where you're seeing the patient often, they're seeing their therapist once a week, even twice a week sometimes, and they're still not getting better. And then clearly if someone has acute safety concerns, then you're going to send them to the emergency room. Cognitive behavioral therapy, or CBT, is a type of therapy that has the most evidence behind it when we're treating anxiety. So this is not like, let's talk about your emotions, or like sit on my couch. Let's talk about what happened when you were 2 years old. This is like real world, concrete homework. Like what do I do when I'm feeling anxious? And it is based upon how feelings, thoughts, and behaviors are all interrelated. And we can change our feelings and thoughts by changing our behavior. Usually when someone starts CBT, they're going to go like once a week for at least a few months. Medication in adolescents we're going to go with the SSRIs typically instead of the SNRIs as our first line treatment. And that's because they seem to have a faster and greater reduction in symptoms. Also, they tend to have fewer side effects. When selecting a medication, family experience is really important. So if there's a patient whose mom is on Prozac and it's working great for her, like I'm going to go with Prozac. Here are the SSRIs, and then highlighted in green, I think are the ones that we would use most often in primary care. As you'll notice, none of these are FDA approved for anxiety, but they're still very commonly used off-label to treat anxiety disorders. Fluoxetine or Prozac is FDA approved for OCD and depression, and it has a long half-life. So this might be a good choice if someone maybe is going to have trouble remembering to take it every single day. It is activating, so for some people, it can actually worsen anxiety. So maybe it's better if someone has like a lot of neurovegetative symptoms, is depressed. Sertraline, on the other hand, this tends to be like my go-to, my first choice. It seems to have the best evidence for anxiety in kids and adolescents. It might be sedating, so probably want to start it at night for that reason. And then Lexapro has fewer medication interactions and it only goes up to 20 milligrams. So it's kind of like more user-friendly when you're trying to titrate up. I don't think I have time to go through these other ones that I just don't end up using really. When we're starting an SSRI, we'll start at a low dose. That's especially important for people who have anxiety or who have panic because they're more likely to be sensitive to the physical and emotional side effects of an SSRI. And then we're probably going to go up on the dose like every 2 to 4 weeks, more often for someone who is on an SSRI with a shorter half-life like sertraline. So maybe you want to ideally see these patients, like if we're starting an SSRI, have them come back like every 2, 3 weeks for the first, 2 months or something. And then after that, maybe stretch out the visits every month, 2 months, 3 months. But there's not really good guidelines on that. I mean, but I would definitely try to have them come back when you start an SSRI at that 2 to 3 week point. We want to advise families that there will be a delayed response. This is not like taking an antibiotic for strep throat. It's going to take a while for this to kick in. And you might start to feel something at 2 weeks, but we're not going to get the full effect until a few months. And if the patients have any concerns about the side effects or they don't like it, before they just stop it, they need to call the office because they can end up having a discontinuation syndrome. If someone is on an SSRI and you've got them at a good dose, so not a low dose, but you've got them in that therapeutic range and they've been on that for, like a month or something, and it's not helping, then you want to consider switching to a different medication, maybe a second SSRI or possibly an SNRI, and try that instead. And people always want to know, like, is she going to be on this forever? And we don't know is the answer to that. Probably not. What we do know is that we probably want to treat the symptoms. We want to treat her until at least a year after they're in remission. And at that point, consider starting to taper down the SSRI. But when you're going to do that, don't do it when the person is leaving for college or something like that, like some big stressful event, and when you're not going to end up seeing them that often. Do it at a time where they're going to be home and you're going to have access to see them. We also want to counsel patients that side effects are usually mild and they appear early. So they're going to appear in the first day, few days, and they tend to improve with time. So if you can kind of like wait it out a little bit or do supportive care, it's usually not bad enough that you're going to need to stop the medication. And the side effects tend to be GI related. They can also have dry mouth, headache, tremor. That's usually at like a high dose. weird dreams, and then changes to their sleep and maybe changes to their weight. Another side effect is activation. So activation tends to happen like when you first start a medicine or when you go up on it. And they will say that they're feeling restless, maybe they're not sleeping as well, maybe there's some disinhibition. And so sometimes it can be kind of like, okay, wait, is this person manic? It can be a little bit confusing. But if this happens right around the time of a dose increase, and then you think it might just be activation, if you go back down on the dose, these symptoms should go away. And that's different from mania. So with mania, yeah, you might have some of these symptoms, but also you're going to have a persistent elevation in mood probably. And mania tends to happen like way down the road and not related to like a specific dose increase like that. And then some of these other symptoms are more unusual. Sexual dysfunction that can occur, and it can be a reason that a teenager or a young adult stops the SSRI and then doesn't come back to see you again because they were experiencing that. SNRIs in kids. So there's only, there was an AHRQ review that said that there's only 2 SNRIs that have enough data to be able to even like use clinically in kids, or to recommend, I should say. There is venlafaxine and duloxetine. Venlafaxine has been associated with increased suicide and some overdose fatalities, and it does have discontinuation syndrome. On the other hand, duloxetine or Cymbalta, this is FDA approved for pediatric generalized anxiety. So this is the one maybe you want to consider as maybe like a second or third line. And although it is also associated with hepatic failure and Stevens-Johnson. There's a black box warning on SSRIs that came about in the late 2000s because there was concern about a link between starting these medications and increased suicidality. And unfortunately, after the black box warning, prescriptions went down, and then actually a suicide rate went up. There was this big meta-analysis from 2015 that showed that kids with anxiety put on these medicines do not have an increased risk in suicidal ideation. And on the other hand, they really are helpful for them. So number needed to treat for anxiety, meaning how many people do we need to treat with this medication before they're in, when we actually are effective or actually works, are 3. Versus the number needed to harm, where harm is suicidal thoughts, is 143. So we'd have to treat 143 patients before one of them has an increase in suicidal thoughts, not even suicidal behaviors. So it definitely seems to be worth any sort of like very small risk. Other medications, unfortunately in adolescents, a lot of the data is lacking. Like things that seem like they might be helpful in adults, it doesn't end up panning out so much in kids, or we just don't have the studies in kids. Benzodiazepines, there's no evidence in placebo-controlled randomized trials that this is helpful in adolescents. And of course, we run the risk of dependence and diversion. Some people, especially the younger kids, have a paradoxical reaction where they're even more anxious after taking one. Where it could be useful, I think, is that if you're starting somebody on an SSRI and maybe they have like panic disorder, is you could potentially prescribe a very small amount, use as kind of a bridge as we're waiting for the SSRI to kick in, and as they're working on the behavioral modification. Propranolol, I think this can be useful, and it's kind of underused in performance situations. So somebody who's nervous when they're public speaking, or if they have a violin recital, taking a 10 or 20 milligram dose of propranolol half an hour or an hour before, it helps stop this cascade of physical symptoms that happen in a panic attack. Like it helps prevent your heart from going up super high and your face from flushing, which then during panic or just makes you even more nervous. Then you're, oh my God, everybody can tell that I'm red-faced. They can all see that I'm sweating. So it helps stop that cascade. Buspirone, there was no difference in studies in kids. Hydroxyzine, this is a sedating antihistamine. So it can help some, I don't know, in my experience, like it didn't really help that much, but maybe for a few kids, they thought it did. But It's not going to really hurt anybody. It's just an antihistamine. It can make people pretty drowsy though. Okay, so then I have some cases here, or unless anybody has any questions that they want to bring up before I would go on to cases. Okay, I'm gonna go ahead then. So Claire is a 14-year-old with social anxiety disorder. She can't stop worrying that she said something weird yesterday to her friends. She's very quiet because she doesn't want to have them all looking at her. Can you all think of any advice that you might give to Claire about how to deal with this situation? And you can just put it in the chat or raise your hand. Okay, somebody said go out with the friends. Okay, so I think maybe what you're getting at is that you don't want to avoid seeing them. And I would definitely agree with that. Whoops. Okay, some other thoughts would be, oh wait, somebody else said something here. Oh, ask the friends. Okay. I don't know. You know, I guess it depends on, I can see how that might be, if it really is like a rational fear, then maybe you want to address it like head on with them. But we also don't want to encourage like the reassuring type behavior where you're having a thought that's related more to anxiety and is not a helpful thought. And then you're going to seek reassurance all the time. Like, did you think that was weird? Because that's not going to be helpful. What I would say is, okay, wait, one more comment. Bring up something that everyone is interested in, Taylor Swift, etc. Yeah, of course, Taylor Swift. Everybody loves Taylor Swift. It's always a good thing to bring up in conversation. I love that you brought up that you made a recommendation that's so concrete. I completely agree with you. You can talk to her about how do you talk in these situations? Well, you don't need to bring your whole stand-up routine, right? You can just even ask somebody a question when you're in a group situation like this. You don't even have to offer anything. And the people in your group are going to think you're the best conversationalist in the world when you want to talk, when you want them to talk about themselves. Like they're going to love you. Other ideas are, you could talk about how worry doesn't change anything, right? So if she's worried she said something weird yesterday, just thinking about it and worrying about it and like picking the situation apart, like it's your PhD thesis, is that helpful? Does it change that you may have said something weird? No, I still may have said something weird. And you probably will never know for sure what your friends thought. So that's an unhelpful thought. Also just accepting, yeah, maybe I did say something weird and like I'm still here. Or thinking about if my friend somebody you really trust and you think is cool, if that person said the same thing I did, what would you think? Oh, well, I'd be like, and then I would immediately forget it. And then finally, fake it until you make it. If you're in a situation where you're nervous socially, just look at the person who seems to be relaxed and copy what they're doing. Laugh. If any of you guys listening were old enough to see like Ed McMahon on Johnny Carson, all I would do is just laugh, laugh, laugh at everything. Just do that. Do baby steps. But also mimic the physical body language of somebody who is confident and relaxed, even if you don't feel it. If I sit back, put my arm up here, I'm tricking my body into thinking that I'm not in a dangerous situation. Like I am safe, I'm okay. Okay, and then somebody wrote in the chat, help identify alternative good peer groups that tend to be more supportive with boys that might be appropriate martial arts. Okay, well, I'm definitely in favor of the exercise. But yeah, I don't know. I don't know if this is an issue with the friend group per se. When people have anxiety about their social circle, we don't really know if that assessment is accurate or not, right? I mean, her friends could be very supportive and nice, but she's kind of fallen into this trap of maybe irrational thinking. Of course, if the friends are rude to her, then that's a whole nother story. All right, next one. Jack is a 15-year-old with generalized anxiety. He has daily stomach aches and headaches and misses school frequently. He's refused to go to therapy. Why would I want to talk to somebody about my life? I'm fine. What do you guys think about this? Do you have any thoughts about how you would approach this in a clinic? Okay, so I've, obviously this is not uncommon that we have an adolescent who's, saying to us, like, you don't know what's going on, I'm fine. Okay, I'm sorry, I'm reading through these comments in the chat. So somebody wrote, whoops, this is going quickly. Your symptoms indicate that maybe you're not as fine as you think. So yeah, you could say like, it sounds to me like with these headaches and stomach aches, like your body is crying out for help. So sometimes even though we think we're fine, our bodies are like, no, we're not fine. It's affecting school, so it isn't fine. Maybe things could be better for you. Well, these are great comments. Motivational interviewing, absolutely. Well, there are some signs I'm concerned about. Yes, great. I agree with all that. Those are, I can see you all have a lot of experience dealing with a situation like this where someone is not ready for help. So you can say, absolutely, like, I am really worried about you. And with all of this missed school, is that affecting your life in any negative way? Is that stressful for you that you're missing so much school? Well, yeah, now I have to do summer school, or yeah, my mom's on my case all the time, something like that. You could also say, if you could wave a magic wand and all of a sudden the stomach aches and headaches would go away and you'd be back in school, would you want that? And they'll usually say yes to that. And I say to them, like, you deserve to feel better than this. And what's the worst thing that would happen if you went to therapy? Like, just try it once. It'd be really annoying and I like hate the person. Yeah, and you'd lose out on an hour of your time. But what's the best case scenario? Is it you'd see somebody, you talk about yourself, maybe it helps a little bit. I think it's worth a shot. I think it's worth that risk. Okay, and then somebody wrote, I like to talk about getting skills and tools from therapy, not necessarily stereotypical laying on a couch. Often families respond to this. You did mention this. Completely agree with that. My daughter had anxiety and we started daily meditations together, game changer for both of us. That's awesome with meditation. I do have a link to a resource at the end of this talk. A lot of this too is all about experimenting and trying things that might work for you. And if they don't work, who cares? Like, I mean, at least you just tried it. Also, I like to try to destigmatize treatment. I personally think everybody could benefit from going to therapy. We all see a dentist every 6 months for our teeth. Our brains are like a million times more important for our teeth. It's helpful too to have an idea of, depending on your clinic situation, people in your community, like who would be a good match for your patient. Because it can be hard for a teenager, like when we're really pushing them to get to therapy and they finally try it and it's not a good match with like personality or expertise or whatever. So want to try to make the best match we can from the beginning. And then if somebody really is against going to therapy when they need it, there are books out there about with CBT principles in them that can be very helpful and that talk about some of these like cognitive distortions and how to look at thoughts as illusions, things like that. And there's also apps too that, and there's more and more research on them as well, and they might be helpful. Okay, last case. Mia is a 16-year-old with generalized anxiety. Mia and mom text frequently during the school day because Mia feels stressed out. Mom also texts to check in at soccer and when she's at Starbucks because these scenarios are also a source of stress. So what do you think about this scenario? What would you advise to the family? Okay. Mind Over Mood is a great CBT workbook. Okay, I am going to check that out. Thank you for that recommendation. And then we have back off mom. Sorry, not sorry. I totally agree with that. Mom needs to stop texting to check in. Yes, exactly. So don't enable the behavior. Very right. So mom doing this, she's very well-meaning, right? She's worried about her daughter. She sounds like she might have anxiety about what's going on with her daughter. But this frequent check-in undermines a kid's confidence and independence because you're telling them like, You can't do this on your own. You need me. I need to check on you. And also, if you're not doing well, that's so serious that I have to know about it. And she's missing out on coping opportunities. If her coping is texting her mom, that's not a good long-term coping skill. She needs to be able to kind of sit through this discomfort and wait it out, or figure out how to manage that herself. Our goal for our kids and for our patients is that they learn how to tolerate stress. It is not that they avoid discomfort. Discomfort, we cannot escape it in our lives. It's a part of the human condition. Our goal is that they learn how to tolerate it. Whoops. Okay. So pearls, as we conclude, physical symptoms are very common relating to anxiety in adolescents. Avoidance perpetuates anxiety and is the primary source of impairment. Anxiety disorders can be treated in a primary care setting with SSRIs and CBT. And then here are the resources. And like I said, I have even more for mindfulness, and I have some CBT books as well. If anybody's interested in them, then just let me know. You can also always send consults through the MAVEN project, through the website. If you have a question about anxiety or another mental health condition, I'm so happy to help from a primary care perspective. And then there's two more comments in the chat. I would love the additional resources. Okay, I'll send them on to you all. Are there any other questions that anybody has? Okay, you're welcome. Thank you all for having me today.
Thanks so much, Dr. Musacchio. It was a wonderful talk and really great questions and feedback from all the attendees. And a huge shout out to all the providers working in clinics caring for underserved patients. You guys do an amazing job, and your patients are really lucky to have you. And we're so happy that you're here and learning with MAVEN Project. Hope you have a great rest of your week and a wonderful weekend.
Thank you.